Progressive chronic conditions are one of the greatest challenges in the healthcare system. Today, there are about 800,000 people with end-stage renal disease. By 2030, we're going to likely see close to 1.2, 1.3 million patients with end-stage renal disease. This condition is really one of the most complicated in the sense that patients, to survive, they need to get dialysis services multiple times a week. It's life-sustaining.
When one looks at the Medicare costs for taking care of patients with end-stage kidney disease, they occupy approximately 7% of the Medicare budget, but care for only 0.5% of Medicare beneficiaries. So when the government and CMS look at the cost of dialysis, they see it as excessive.
Government has a very large responsibility for patients with kidney failure. And designing a payment system has taken many years through many iterations of legislation in Congress, but what they've settled on is a prospective and bundled payment for these patients for their dialysis needs throughout the year.
So the economics of dialysis have become very difficult. Medicare has essentially held their payment steady over the last 5 or 6 years, despite the fact that between inflation and rising labor costs, our costs in providing that care have increased substantially. So the margin that's available to a dialysis provider is now estimated, according to MedPAC, to be between 0 and 1%. So with that margin, we could not stay in business if we had a dialysis center that was filled completely with patients with Medicare insurance.
What happens in dialysis is that roughly 90% of your patients are in a government program. But the combined revenue from all of the reimbursement for those patients only covers about 2/3 of the total cost of care for dialysis patients. Where's the rest of the third coming? Commercial payment makes up the difference. So for the 10% of patients who have commercial or private coverage, about 1/3 of the total dialysis system costs come from those 10% of patients.
So we remain, as dialysis providers, dependent on the private-public partnership. If we don't have enough commercial payers, it means we have to find ways to cut costs elsewhere. We feel that it's very important that we keep the clinics open and that we provide access to care. But when a dialysis facility is losing money and we don't have commercial insurers to help support us, we don't have a lot of choice but to close clinics.
Value-based care is all about how providers can figure out ways to improve outcomes for the same or lower costs. And this is going on in every aspect of healthcare now, and it's the main conversation over the last 20 to 30 years in healthcare policy, because it's not always easy. How do you switch from a whole mindset that was based on reimbursement for volume to reimbursement for value?
Dialysis providers and physicians will prescribe certain medications or certain treatments only if they know that it's not going to cost the patient a lot of money and that that medication or treatment is going to be paid for adequately. So patients can be restricted from receiving what might be optimal for an individual patient because payment isn't there.
If we can help to reward dialysis providers for the better outcomes that they're providing for this vulnerable, complex population, there could be ways to help everybody, public and private, better manage the costs of these patients.
When I look at the future of the dialysis bundle, I think there needs to be a reevaluation of Medicare margins. I think that the CMS needs to recognize that there needs to be a margin that allows dialysis providers to stay in business. And that margin should depend on the costs and should change as costs change.
Incentives are really important for keeping the public-private partnership strong, but assuring on both sides of the equation that private payers continue to hold up their end of the bargain, and similarly, public payers continue to offer enough resources to the system that everybody's sharing the cost of these very expensive patients equally. I think there's a lot of opportunity with value-based payment models in terms of how can we help the 30 million people with chronic kidney disease not progress to kidney failure? What kind of interventions can we provide earlier that down the road won't end up with people on dialysis?
Policymakers need to think about what's best for patients. We as dialysis providers always keep our patients first and foremost. And we would love to be able to partner with regulators and legislators to really put the patients first.
Everybody has an incentive to and a responsibility to take care of this population. The big picture question is, how do we pay for these really sick patients? Because people can't pay for themselves.